Yeah, now we can.
Okay, thank you. It's really a pleasure to be here today talking about atrioventricular septal defect. I would like to start off by saying that it's a group of malformations that's unified by a common atrioventricular junction together with biventricular atrioventricular connections. And you will know, of course, that this defect has been given various names over the times. To start with a normal atrioventricular junction, we find that it has a figure of 8 configuration, and it has an aorta tucked into the waist of the figure of 8. Whereas by contrast then, in this case, with an atrioventricular septal defect, we have a more or less oval shape. Sometimes there's a little bit of pinching in on either side, but not a great deal. And we see that we have a very anteriorly positioned location of the aorta instead. So we have kind of very different configuration across the atrioventricular junction. And therefore, with an atrioventricular septal defect, we have a different formation of the valve guarding that atrioventricular junction. We can have 5 leaflets in both settings, but then we may have variations whereby the superior and inferior bridging leaflets are not connected to one another versus the ones where they are connected and therefore separating that common atrioventricular valve orifice into 2, the so-called ostium primum kind of defect. And now looking up from the apex in these hard specimens, the normal versus the atrioventricular septal defects, we can then find that in the normal configuration, the aorta is tucked into the waist of that atrioventricular junction, and you have sort of oblique alignment of the peppery muscles supporting the mitral valve, whereas the arrangement is very different in hearts with atrioventricular septal defect. And you will see that we have 5 leaflets looking up from the apex, and we have more or less superior-inferior alignment of the peppery muscles supporting that left-sided atrioventricular valve. That means that in the left ventricular side, you would tend to find 3 leaflets configuration instead of the mitral kind of configuration. And furthermore, then we have the so-called cleft, which is actually a zone of apposition between superior and inferior bridging leaflets. And of course, in your 4-chamber cut, then it's quite obvious that versus the normal, we have lost the offsetting arrangement between mitral and tricuspid valves. Instead, we tend to have a hole in the middle of the heart. And now moving on to the levels of shunting, owing to the differences in arrangement of the superior and inferior bridging leaflets. For instance, in this case, we see that the superior and inferior bridging leaflets from both the right ventricular and left ventricular aspects, they are plastered down onto the crest of the ventricular septum, meaning that we have communication potentially at the level of the atrial chambers. Versus this variant, whereby superior and inferior bridging leaflets are not plastered to the crest of the ventricular septum, they're not joined together. Instead, you have some sort of flow that you ventricular communication underneath both superior and inferior bridging leaflets. And also you have a communication above the atrial surface of the leaflets, giving both inter and atrial and interventricular components to the defect. And we can have within this group also a so-called transitional or intermediate type, whereby the leaflets are joined together, the superior and inferior bridging leaflets are joined together, but then separating interatrial and interventricular components. And the final type of variant in terms of levels of communication is this type, whereby the leaflets are actually attached to the underside or the free edge of the atrial septum. You see the oval fossa, a large coronary sinus here, and we turn around to the left ventricular side here. Again, we see that superior and inferior bridging leaflet here. And turning down to the left atrium, left ventricle, and we see again the leaflets attached more or less to the underside free margin of that atrial septum, thereby giving you the level of communication at the ventricular level. And this diagram just summarizes the three variants of potential communications. Then there's interest also, I think, among the surgical community in terms of the extent of bridging of the superior bridging leaflet. So in this instance, we have minimal bridging, and in the specimen looking at the posterior half of the heart, we have superior bridging leaflet here, a lot of attachments along the ventricular septum on the right side, so minimal bridging. Versus intermediate bridging or type or Rastelli B type, whereby we have an anomalous papillary muscle sitting here, so bridges a little bit more into the right ventricle. An extreme bridging in this example, C type, whereby there's a kind of bifid papillary muscle sitting here, a lot more of the superior bridging leaflet into the right ventricle. The consequence of a common atrioventricular junction also impacts on the outflow tract, as we see here, the left ventricular views. The inlet and outlet components in the normal are practically equal, whereas in atrioventricular septal defect, the outlet component is longer versus the inlet component. And furthermore, it tends to be narrow as we go up into the aorta. And this image looking at the heart from the front gives a sort of typical gooseneck appearance. The impact of that already inherently narrow outflow tract is shown here. We made a study looking at the impact of the scoop of the defect versus how much extension, anterior superior extension of that defect is into the outflow tract. And to our surprise, in our heart specimens, we found quite a proportion of hearts with complete atrioventricular septal defect that had this sort of excavation of the defect towards the outflow tract, which may impact upon a single patch repair, for instance. And further additional things may add on to the outflow tract obstruction, for instance, fibrous tissue tags in this example, an accessory papillary muscle in the other. With regard to the conduction bundle, we know that it's displaced. It's not in the triangle of Koch anymore. Instead, it's very near to the coronary sinus orifice. It's right where the ventricular septum comes up to meet the atrioventricular junction posterior inferiorly. And we tend to have an elongated atrioventricular conduction bundle before it bifurcates, usually a little bit to the left side of the crest of the ventricular septum, but in some cases it can be right on the crest of the ventricular septum. And here we show the difference between the two forms, the complete form and the partial form. In the partial, there's a bit of protection provided by the valve tissues. Associated defects then. We've talked about left ventricular outflow tract obstructions. There are various entities, which I will try and show some examples of. In this case, it's associated Fellow's tetralogy. We see the deviated anterocapillary deviation of the outlet septum overriding aorta here, and left ventricular view on this side. With atrial isomerism, the thing to remember about is the conduction bundle varies. So when we have the morphologic right ventricle on the wrong side of the heart, and we have the left ventricle on the right side, we tend to have a conduction tissue sling in both left and right isomerism examples. And finally, the sort of unbalanced ventricle situation, or chamber situation rather, you can have aligned septa, atrium ventricular septum, or you can have a malaligned septum of one sort or another, impinging on one of the chambers. So unbalanced. So an example here then, in this situation, very small left ventricle and very small left atrium. Another example, but this time with a partial atrioventricular septal defect and double outlet right ventricle as well. And in this instant then, there is a rightward deviation of ventricular septum that comes up to the atrioventricular junction. So a small right ventricle, right atrium, left atrium coming, right atrium opening both to right ventricle and left ventricle. In this instance, it's important to bear in mind that the conduction bundle is displaced rightward following the ventricular septum. So I hope I've given you a sort of summary of these sort of things that you might encounter in atrioventricular septal defect. It all impinges upon understanding that the atrioventricular junction is grossly abnormal compared to the normal situation. So we are talking about common atrioventricular junction in hearts with biventricular atrioventricular connections, and the inlet and outlet disproportion that might sort of impact on how you're going to do your repairs. So with this, these are my coordinates. And thank you very much for having me.